अभी शुरू तो नहीं किया ट्रांसमिशन। ठीक है। मेरे को पता कैसे लगेगा कि कितने लोग लॉगिन कर गए हैं? नहीं पता लगेगा।
वो इधर आते हैं सर,
इसमें आता है।
हाँ जी
तो अभी कोई है ही ना?
ये सर एक स्टूडेंट है वो सर, मॉर्निंग वाले दो एक तो फिक्स ही हैं सर वो।
हाँ कोई बात नहीं, ठीक है। उसमें कोई बात नहीं, उसमें चैट कर सकते हैं ना?
हाँ जी हाँ जी।
Okay, good morning to everyone. So, I'm Dr. Atin. I'll be today speaking on evaluation of plain X-ray abdomen. There's the slight change in the program. I hope you guys were aware of it. So instead of Dr. Shivanand's talk, I will be taking my talk today, and he will have his talk later on. So what is the role for plain X-ray abdomen in the clinical settings? Nowadays we have good modalities like ultrasound, CT scan available. So are we doing plain X-rays abdomen routinely? If not, then what is the indication which is still left for plain X-ray abdomen which can be done? So let's just go into it. So once a X-ray abdomen is indicated, we need to decide which X-ray has to be done. It can be a abdomen erect. Erect means when the patient is in an erect position, either standing or sitting position. It can be abdomen supine when the patient is lying down. If the patient is sick, obviously he cannot be made to stand, so the X-ray has to be taken in a supine position. Then in certain circumstances we take a abdomen lateral, left lateral decubitus film. I'll tell you why. And then rarely we have to take a abdomen prone film also, in which the patient is put prone. This is specifically done when we have to differentiate a ileus from a small bowel obstruction. Okay. So this is a typical example of how a plain X-ray abdomen looks like. I just want to spend a couple of minutes here trying to apprise you of what different shadows we see on a plain X-ray abdomen. I'm sure you guys are aware that on a plain X-ray we can see different densities which we can differentiate from each other. So this is the bony density. These are the vertebrae which are seen, these are the iliac blades which are seen, these are the ribs which are seen. So this is clearly a bony density which can be differentiated from any other density. Then there is a soft tissue density like this generalized gray or whatever you want to call opacity, white opacity, is a soft tissue density. What we call it is a soft tissue density. Even this is a soft tissue density, this is a soft tissue density, this is a soft tissue density. This is a common density, common opacity for all solid organs as well as fluid. On X-ray, plain X-ray, we cannot differentiate a solid from fluid structures, and both of them give rise to a soft tissue density like this. So with our anatomical background, we would know that the soft tissue density which is seen on this right hypochondrium is a density of the liver. One which is seen in the left hypochondrium is the density of the spleen. This density, you can see a sharply marginated line to this density. This is what? This is a muscle. This is psoas. I cannot tell that this is a muscle based on the density alone, but what I know by my anatomical background, any soft tissue which is running from the vertebral margin like this, flaring out down, is likely to be a psoas, right? Even this is abdominal wall. This is a kidney density. Can you just see this outline here? This is a kidney density. Okay. Then another density which is seen on X-ray is a fat density. Fat is slightly darker than soft tissue, but not as dark as air. Okay, I'll first show you air density. This is air density. This black part, this is air density within the bowel loops. We expect air in the abdomen to be only in the bowel loops, or air has to be outside into the external environmental air, atmospheric air. So this is air within the bowel loops. This is air density. Fat density is slightly brighter than air, otherwise difficult to appreciate, but somewhere like this maybe this area, this is all fat density. Where is fat in the abdomen? It is within the mesentery, within the fascia. That is where the fat is in the abdomen. So this outline what you see for the psoas is seen because there is soft tissue density of the psoas, and the fascia or the outline to it is lined by the fat in the small fat in the retroperitoneal tissue or in the fascia. That gives rise to this margin of soft tissue density of the psoas. Similarly, this margin of the liver, you can see this lower margin of the liver. This is visualized because this soft tissue density of the liver contrasts to the fatty mesentery or the omentum which is adjacent to it. We are able to see the margin only when there are two different density opacities adjacent to each other, therefore it gives a contrast. If a soft tissue density is adjacent to another soft tissue density without any intervening different density structure in between, will not be able to see the margin between one versus a 2. So for example, even the gallbladder lies here, exactly in this location. It would be containing fluid. I've told you fluid density will be same as the soft tissue density. So the, the gallbladder will also be having the same density, but we are not able to see the gallbladder here. Why? Because that soft tissue density overlaps the liver soft tissue density, and we cannot differentiate because those are both same density structures. There has to be a different density structure for you to identify it, especially if it is adjacent to another structure. Okay, we'll see more examples later on. So what is this air? This air is in the large bowel. Yeah, this is laterally located. This is in the shape of the transverse colon. This is in the shape of the ascending colon. This is in the large bowel. This small point of air may probably be in the distal ileal loops. What is the last different type of density which you can see on the opacity, which you can see on the X-ray, is a metallic opacity. Okay, so this is a metallic opacity. What is this? These are the numbers or the which have been assigned to this X-ray. This is a old X-ray in which we used to place metallic numbers over the patient's abdomen by a sticker for an identification mark, and this is the metallic density which comes. You can identify it very different from even the bone density. So these are the different opacities or densities which can be identified on the plain X-ray abdomen. So let's see a different example. Again, this is metallic opacity, right? This is bony opacity. Now you can see air within the large bowel here. Air. This is also a loop of the transverse colon only actually. Air. This is air in the rectum. Okay. This is in the air in the descending colon. This is liver opacity. This is splenic opacity. What is this? This is another rounded opacity which is slightly denser than the kind of bone opacity. Yeah. So this is either something within the abdomen, or remember, since X-ray is a two-dimensional projectional image, anything from anterior-most to the posterior-most part will be coming in between the rays and will be giving opacity. This is actually a button on the clothing of the patient which has not been removed. This comes with experience. By shape we know that this must be obviously outside the abdomen if the clothing has not been removed. Theoretically, the patient could have ingested the button and it could be in the small intestine or the large intestine, but most likely causes it is on the surface of the abdomen and it would be projecting over it like this. Okay. So once you know what are the different structures on the plain X-ray abdomen which you are supposed to see, let's see what all to examine. We need to examine the normal structures methodically, one by one, looking at the liver densities, spleen density, kidney densities, psoas densities, air densities, bony structures, any calcifications, any metallic structures. Yeah. Then we look at the gas pattern. We look at if there is any extra luminal air. Air within the bowel is normal, but air outside the bowel is abnormal, and that is one of the most common indications still present to get a plain X-ray abdomen done. Okay, so let's see them one by one. Let's see the normal structures. I have already told you the normal structures, the liver, the spleen. You may not be able to see the entire lower margin of the liver always. You may not be able to see the lower margin of the spleen always. That's okay. It may not be seen, but this is the density of the liver, this is the density of the spleen, this is the density of the left kidney, this is the density of the right kidney. Overlapping it is the air within the small and the large bowel. What you need to see is that the air pattern is also fine. Okay. What is this? This is again hooks in the patient's clothing. So we should not be confusing it with anything abnormal, and we should be able to identify it. Okay. Then coming to the gas pattern. Okay. Let's see the gas pattern. There has to be once the patient is in an erect position, you all I'm sure would know that most of the hollow viscous in the body, the stomach, the small intestine, the large bowel, has air as well as fluid within it. So once the patient is in a standing position, because of the gravity, the fluid comes in the lower dependent part, air comes in the non-dependent part, and if you take a X-ray which is beam which is going perpendicular to the patient's body, so like if the patient is standing erect, then you would see obviously air on the cranial part, fluid in the caudal part in one bowel loop, and that would form a air fluid level, because the fluid's topmost margin is always a straight. That is just plain physics principle, that any fluid in any uh, hollow viscous or any container would have a top horizontal margin. So if you see soft tissue opacity in anywhere in the abdomen in which the superior margin is a flat straight horizontal line, you can tell that that soft tissue opacity is of a fluid and not a solid. Remember, I told you earlier that a soft tissue opacity of a fluid and a solid exactly appears same on a radiograph. We cannot differentiate it. The only way to differentiate between the two is if you see the upper level of that soft tissue opacity is a horizontal flat level, you can infer from it that this soft tissue opacity represents a fluid. If you do not see a horizontal upper level, it may still be fluid, it may be solid. Only when a gas is present adjacent to that fluid, it will have a soft tissue level. If the fluid is within combined a full shape, it will not have a soft tissue level. Let's say a fluid in the urinary bladder. When the urinary bladder distends, there is no fluid. The whole urinary bladder is occupied by fluid. It will not have a horizontal shock level even if you make the patient stand erect. Similarly, in gallbladder also, there is fluid, bile is fluid, but it will not have a horizontal upper level. But in the bowel, since there is air also besides the fluid, it will always, not always, but it will often have a horizontal soft tissue level if both air and fluid are level in that one particular segment of the bowel loop. So that's how we see the fluid levels, and I'll show you. So this is the erect film. You see this particular area, there is a air opacity. Yeah, this is the air opacity. The lower margin of the air opacity is exactly horizontal. What this means is that the soft tissue below it has a upper horizontal margin. So if you see this level, this is a air fluid level, and again even in this air margin there is a horizontal level to the lower margin. These are air fluid levels in the small bowel. This is air fluid level in the stomach. Any air fluid level seen in the left hypochondrium, we anatomically correlated that it most likely would be present in the stomach, because stomach is the one of the most common places where you would be expecting to see air fluid level, just because of the huge capacity of the stomach. There will always be some air in the stomach. It cannot be, it usually cannot be completely fluid distended. Okay. Presence of multiple air fluid levels is a sign that there may be a small bowel obstruction. 2 to 3 air fluid levels normally seen. Stomach air fluid level normally seen. One level in the cecum may be normally seen. But if there are more than 2 to 3 levels, air fluid levels, and large air fluid levels, then it is a marker for bowel obstruction. Because once there is bowel obstruction, there is holdup of fluid in the proximal bowel and gas also. It would lead to multiple air fluid levels, and therefore we are trying to look for air fluid levels. Then what is the difference between a small and a large bowel obstruction? Okay, I'll show you with examples. So let's see what is present here. Are there any abnormal air fluid levels? No, I can't even see a air fluid level in this particular case. This may be a supine X-ray. This may be normal, even this may be normal. Okay, let's see examples here. So this is obviously a child's X-ray. This has been done erect or supine. Just by seeing the X-ray, we can tell that it has been done erect. Why? Because whatever air I am seeing in the abdomen has a lower horizontal margin. That means there is a opacity, soft tissue opacity below it, which has got a upper horizontal margin. So there is fluid here, there's air here. This has to be air fluid level. This has to be air fluid level. Okay, so there are two large air fluid levels, one in the left hypochondrium, one in the right hypochondrium, and rest of the abdomen does not show any air or any air fluid level. No air in any of the distal segments of the bowel is seen. What it signifies is that there is a proximal bowel obstruction. In this particular case, this level is in the stomach, this level is in the duodenum, and there is a duodenal obstruction. In a duodenal obstruction, complete duodenal obstruction in a child is a marker for duodenal atresia. There is no air which is going into the distal bowel because the complete duodenum atresia is present. Okay, let's see this particular patient. This is an adult patient. Obviously, a erect X-ray. Why? Because you can see a air fluid level here. This air fluid level obviously is in the stomach. I have told you we are expecting to see air fluid level in the left hypochondrium below the left diaphragm in the stomach. But besides that, whatever air I am seeing in the small bowel is also more or less having a horizontal levels below it. So this is air fluid levels in the small bowel. Okay, I'm showing you another example. This is an easier one to comprehend. Can you see this straight line here? 1, 2, 3, 4, 5, 6, 7, 8, 9, multiple air fluid levels with dilated small bowel loops. All this air fluid levels in small bowel loops, this is definitely much more than what can be normally expected. So there is bowel obstruction. Which bowel obstruction? Is it small bowel? Is it large bowel? The large bowel is supposed to be at the periphery of the abdomen. It is not dilated. It is not showing any air fluid level. Only the central loops of the bowel, which are situated in the central part, expected to be the small bowel, is showing you multiple dilated air fluid levels. So this is small bowel obstruction somewhere in the distal ileum. So the jejunum and the ileal loops are dilated. This is a erect film. If you were to take the supine film of the same patient, this is what you would be expecting to see. On a supine film, you are not going to see air fluid levels. Why? Because once the patient is lying supine, the air is on the non-dependent part, which is the anterior part. The fluid is on the dependent part, which is the posterior part. So once you take the X-ray in a supine position, the X-ray first crosses the air, then crosses the fluid, then reaches the X-ray film or the detector. Both air and fluid overlap over each other. They are not separated, so there is no air fluid level which is seen. This is what is expected to be seen. What you only see on a supine film is a dilated bowel loops. Is this bowel loop dilated? Is this normal? I showed you multiple normal X-rays previously. You would not be seeing such prominent air containing loops anywhere in the abdomen. So if this is more than 2.5 to 3 centimeters in size, yeah, and multiple of them seen, you know that this is a small bowel obstruction. Why is this small bowel? Why is this not large bowel? This is in the central part of the abdomen, right? The bowel loop diameter is maximum up to, the small bowel can dilate maximum up to 4 to 5 centimeters, can't dilate beyond that. That's the maximum lumen it can have, right? And you see this structures, this is a soft tissue structures. What are these? These are the valvulae conniventus seen in the jejunum. So if you see this, these are thin, these are continuous, these are parallelly oriented, equidistant from each other. These are characteristic of jejunum. They are not seen in ileum. Ileum is more or less featureless, but the jejunum, so if you see this pattern, you would know that I am seeing the jejunum, and therefore you would know that this is, the jejunum is definitely dilated. Is it small bowel obstruction? Even a obstruction, let's say in the transverse colon, can have dilatation of the proximal transverse colon, can have dilatation of the ascending colon, and if the ileocecal valve is incompetent, even the proximal ileum, the jejunum can also be subsequently dilated. As the duration of obstruction keeps on increasing, the more proximal bowel will go on dilating. So it's not that the small bowel will not dilate in a large bowel obstruction. If time has elapsed, the large bowel and the small bowel, whatever is proximal to the site of obstruction, will all dilate. But here we do not see any large bowel obstruction. We only see the central small bowel obstruction. So we can tell that this is most likely a distal jejunal obstruction in this particular case. Okay. Same thing I have told you about large bowel obstruction. If you see dilated loops at the periphery, like you see, this is at the periphery, this is not more or less in the center. This is definitely more than 5 centimeters. It can dilate more than 5 centimeters, and this is in the anatomical location of the descending colon, the ascending colon. This is likely to be a large bowel. So I can tell the large bowel is dilated, even if the small bowel loops are dilated. But since the large bowel is dilated, if it is obstruction, it has to be somewhere in the large bowel. That is what my role is in telling after looking at the plain X-ray abdomen. Okay. Another example, what do you see here? This is definitely a dilated bowel loop here. Yeah, rest of the bowel does not show any abnormality. Is this a supine film or a erect film? This is likely to be a supine film. I cannot see a air fluid level. and the loop which I am seeing as dilated is also not showing me a air fluid level, so this is likely to be a supine film. What is this bowel loop? Is this jejunum? No, the jejunum cannot dilate this much. If this much dilatation is seen, it has to be a large bowel. What is this? This is haustra. This is one small soft tissue strand from one of the wall. So this is the classical appearance of a haustra. Haustra are present in the large bowel. So once I am seeing this, and in this location, I know this has to be a one loop, one part of the transverse colon which is significantly dilated. So this was a closed loop obstruction of a transverse colon. Closed loop means the proximal and the distal loops both are obstructed. Maybe it is herniating out, and therefore it is leading on to this dilatation of the transverse colon. Same patient. This was the supine film. This is the erect film now. Why is this erect film? I am seeing a horizontal air fluid level. Why is this fluid? Because this got a horizontal upper margin. Otherwise, this fluid density is same as the liver density or the spleen density, any other soft tissue density. I cannot differentiate. But by just seeing this horizontal level, I know it has got to have a fluid here rather than a solid tissue. And now I can see two more air fluid levels, this and this. So this has to be a large bowel obstruction of this dilatation, right? Another example, different example. I can see this dilated bowel loop here, yeah, this much dilatation on the periphery. Again, it is likely to be a large bowel obstruction. What else do I see? I see, maybe, sorry, not this one, this is transverse process of the vertebrae, but this one, this is haustra. So this is actually a sigmoid, sorry, this was a cecal volvulus. Cecum was significantly dilated and there was a cecal obstruction in this particular case. Another example, supine film or erect film. This is a erect film. Why? Fluid level, horizontal fluid level. You see this? This is again fluid level. If you see these horizontal lines, this has got to be a erect film. Where are these horizontal lines present? In this case in the periphery, in this case in the center. So this has to be a bowel obstruction, right? Small bowel is also dilated, large bowel is also dilated. It has to be a large bowel obstruction with an incompetent ileocecal valve, which has led on to even a small bowel obstruction in a prolonged duration. Okay. Then coming to paralytic ileus, even a paralytic ileus would also lead to a bowel loop getting dilated. What happens is that there is inflammation. When there is inflammation in the abdomen, it can be a generalized inflammation or a localized inflammation. What is localized inflammation? Can be anything related to cholecystitis, appendicitis, ureteral calculus, pancreatic ulcer. So once there is a localized inflammation, any small bowel loop which is adjacent to that site of inflammation will undergo will have a ileus. There will be lack of peristalsis. This is the body's protective mechanism actually to protect it, so that there is no more damage which is being done. So if you see a localized bowel loop which is showing dilatation, not peristaltic, you may think in terms of a localized ileus. So I'll just show you an example. If you see this particular X-ray, the rest of the abdomen looks fine. This is air within the large bowel. This is some fecal matter also seen in the large bowel, which is giving rise to this mottled opacity of air in the large bowel. But what you see is this particular isolated small bowel loop is definitely looking more prominent than what I have normally seen. Yeah, it is a focal dilated bowel loop. I've just enlarged it to show it. Why? This was a case of actually acute pancreatitis. This bowel loop is adjacent to the pancreas and it was showing a focal dilatation, focal ileus. This is what we call it as a sentinel loop sign. Sentinel is like a protective thing, like police, adjacent to that particular area which is showing dilatation. So if you see one loop of bowel in one particular area which is dilated, you can tell that this is a sentinel loop and the inflammation in the abdomen is likely to be adjacent to that particular bowel loop if you are clinically suspecting any inflammation. So like if the patient presents with right side abdominal pain, acute sharp pain, it comes to you in the clinical, we are not doing X-ray for that, but if you have done an X-ray, if you see a localized bowel loop, let's say in the right iliac fossa, you would think probably it may be acute appendicitis. If you see a small bowel dilated loop isolated in the right hypochondrium, you would think maybe acute cholecystitis. This can help you to maybe localize the site of inflammation, not something which we use routinely, but nonetheless you should know these were the signs which were used previously when ultrasound was not available, CT was not so frequently available, and these are the signs which were used. What happens in generalized ileus? All bowel loops are aperistaltic, they are dilated, they may be showing multiple air fluid levels. So if you see large bowel, small bowel, all loops dilated, it may represent paralytic ileus. Okay. The point here to differentiate is even a distal large bowel obstruction, let's say obstruction in the sigmoid colon, right, would lead to dilatation of the proximal descending colon, the transverse colon, the ascending colon, and even subsequently all the small bowel loops. That would appear like this only. How would you differentiate that there is ileus versus this? The point to differentiate is in the ileus, all bowel loops will be dilated from rectum to colon to everything. Whereas if it is a large bowel obstruction, the obstruction has to be somewhere distal sigmoid colon, proximal rectum. Beyond that, it will not happen. So if you see air within the rectum or the sigmoid, then it has got to be ileus and not a large bowel obstruction, right? And this is one point where we sometimes, if we are having a doubt, we can do a prone X-ray to look for air in the rectum. Why prone X-ray to look for air in the rectum? If the patient is lying supine, the rectum is not the most dependent part. The sigmoid colon is more non-dependent in the supine position. So air would go up into the sigmoid colon and we would feel that the rectum is not containing air. So there may be distal sigmoid colon obstruction. But if you make the patient prone, just by sheer anatomy, since the rectum is just adjacent to the sacrum, in the pre-sacral space, in the prone position, it becomes the most non-dependent part of the pelvis, right? So any air, if it is present even in the distal sigmoid, would go into the rectum. And if you see air in the rectum, you can tell that there is no bowel obstruction, because no complete bowel obstruction, because air is going up right till the rectum. There cannot be obstruction proximal in the bowel. Again, these are signs which we have been using decades ago, but they are not normally now used to differentiate a large bowel obstruction from generalized ileus, because it is a clinical diagnosis. You can put a stethoscope, you can do percussion, you can do examinations, and generalized ileus patient does not present with generalized ileus. Generalized ileus is most commonly seen in a post-operative period of a major abdominal surgery or even a small abdominal surgery, when there is ileus for a, let's say, 2, 3, 4 days post surgery, because there is significant handling of the bowel loops. That is what is the most common cause for generalized ileus. Patients do not present to the casualty with generalized ileus. It's seen in a proper clinical setting, and therefore we know how to differentiate. Then what else is, once you've identified bowel abnormality, then you need to look for extraluminal air. So you've till now seen air within the bowel lumen, which is normal, right? If it is prominent, it is obstructed. But if the air is outside the bowel lumen, it is definitely a sinister sign. It means that there has to be a bowel perforation. Otherwise, abdomen in the free peritoneum does not contain air. There cannot be any air there. If there is air in the pre-peritoneal space, the most likely culprit is one of the hollow viscus, the stomach, the duodenum, the small bowel, large bowel, whatever. It has actually ruptured and the air is leaking out from it. That is a sign which requires most often operative repair. So this is one sign which we are looking for when we are doing an X-ray abdomen. And if you ask me, this is the most common indication which is now currently remaining for X-ray abdomen to be done in any particular patient, is when we are trying to look for extraluminal air. So let's see how do we see it. When I am talking about extraluminal, I am talking about free peritoneal air. Okay. Again, air, you know how air is seen, but if you are looking for a small quantity of air, you need to see it in adjacent to a different opacity structure. That's what I have been harping on since I started this lecture. Two different opacities adjacent to each other will be visualized better. That is because of the contrast which they give with each other. So if you want to see minimal quantity of air, if it is adjacent to a bowel loop, you will not be able to differentiate whether it is in the bowel or it is in the extraluminal. If you make that air come overlapping the liver, close to the liver or the diaphragm, those are all soft tissue densities, you will be able to identify it better. So what we do is, we make the patient stand erect, yeah, or maybe in the standing position, and when we take a X-ray, then if you, so this is a classical chest X-ray, right? What you see abnormality in this particular patient is, this is the liver opacity, right? This is the diaphragm. So look carefully here. There is a outlining of the diaphragm by this hypo opacity here, which is air. I've just zoomed it up for you again to see. This is air opacity. Over it is the diaphragm. This is the diaphragmatic margin. This is the air. So this is air under the diaphragm. This is known as pneumoperitoneum, or this is a sign for free air in the abdomen. This small amount of air can also be detected on a plain X-ray chest or X-ray abdomen. Either of the X-rays can detect it. Actually, this may be as less as 1 cc of air, 1 to 2 cc of air, 1 to 2 ml of air can be detected like this by making the patient erect, taking the X-ray in a proper position, and this small contrasting it with the liver and the diaphragmatic opacity. Why am I seeing it on the right side? It could be seen even on the left side also, because this, both of them are the non-dependent parts. The right diaphragm is slightly up, so the most non-dependent part is the right diaphragm, beneath the right diaphragm. And otherwise on this side, if I see this air, I may be able to confuse it with the normal stomach shadow also. So it's better to see it on the right side when there is no air containing structure normally present. Here there is air containing structure normally present, I may be getting confused. So if I see it on the right side, it is clear. Okay, another example. This is again a chest X-ray I am showing you. This is air in the lungs, but what you see here is, this is the diaphragmatic opacity here, this is the diaphragmatic opacity here, this is air beneath the diaphragm, both sides. So this is pneumoperitoneum. Okay, right. Another example. This has become clearer now. So there is clearly air beneath the diaphragm here, air beneath the diaphragm here. This is pneumoperitoneum. Why is there no horizontal fluid level to this air here? This is also erect film. Yeah. Why? Because if I see a horizontal fluid level below, that means there has to be fluid below. If I am seeing this shape, so this is not fluid. So there is only air in the abdomen, not fluid. There may be fluid. Once there is bowel leak, there is fluid also. But that fluid will now be in the most dependent part, which will be in the pelvis. Air is here. I can't have a fluid level. Air does not have a lower horizontal margin. It is only the fluid which has an upper horizontal margin. There is no fluid here. So this is only air here, and therefore this air is having a crescentric shape. Okay. So I'm sure now you guys know how to identify a pneumoperitoneum. So now let's look at soft tissue. So once we're done with looking at the air, we also need to look at the soft tissue masses. So let's see examples. Okay, you've now seen what a normal soft tissue looks like. Let's try and identify if there is any abnormality with soft tissue here. So this particular example, what is this line? This is the lateral margin of the psoas muscle. Yeah, I showed you earlier. This is lateral margin of the psoas muscle. Look here. What do you see? This lateral margin of the psoas muscle is going too much laterally here. Compared to this side, it should have been symmetrical. This is going too laterally here, and it gets blurred out here. So I look at psoas margins and all the X-rays which I see. If this is getting blurred out here and there is a soft tissue opacity here, I would think that most likely the psoas in this particular patient is bulky, and there is some soft tissue density lesion in the psoas. Liver, spleen, I don't find any abnormality here. Kidneys, I am not finding any abnormality here. Not to say that this is the best investigation to look at liver, spleen or kidneys. This is not, definitely. But if there is any gross abnormality of liver, spleen or kidney, we may see it on the X-ray. Again, this particular case, is there a gross abnormality? Therefore, I am seeing on the X-ray. This is what I am trying to show. We've done a CT scan for the same patient. This is the psoas muscle on the right side. This is the vertebra. This is the psoas muscle on the left side. This is definitely much bulkier than the left side, and there is an abscess in the psoas. So this was a case of psoas abscess, which was leading on to that X-ray sign. What is the most common etiology for psoas abscess in our country? It is tuberculosis. So actually this was vertebral tuberculosis leading on to a psoas abscess. Okay, another example. Any abnormality we see here? Okay, what I am seeing is maybe there is too much of a soft tissue opacity on the right side in the hypochondrium. The bowel loops are seen here, not seen here. I'm not sure, but I may think that there is a soft tissue density opacity seen here. I can't see the kidney margin outlined pretty clearly. I may just suspect it. So what was done? IVP was done actually in this particular patient. This is a delayed IVP film. This clearly shows that the right kidney is significantly enlarged and hydronephrotic. This is contrast within the pelvic ileal system, and there is a pelvic ileal system pelvic obstruction. So this was hydronephrotic right kidney, which was giving rise to this particular soft tissue density shadow. Fluid or solid, I've told you both will appear same. This is a supine film, right? Kidney के अंदर this is fluid in the pelvic ileal system, appear enlarged and as a soft tissue opacity. Okay. Now let's look at calcification. What is calcification? You know, deposition of calcium on some structures is calcification. Calcification will also be seen as a different opacity on any X-ray, chest X-ray, peripheral X-ray, abdominal X-ray, slightly more dense than the soft tissue density, maybe not as dense as the metallic density. And let's see, calcification can have different patterns. By looking at patterns of calcification, we can try and infer or decipher that what structure in the body has shown calcification. So it can be a rim-like pattern, which is like circular or oval, linear or track-like, like a tram track, like a railway tracks, something linear. Okay, lamellar, where it is uniformly in multiple layers, or a cloud-like or amorphous type, bizarre types of pattern in which there is no fixed type of pattern. It can be any geographical shape. So let's see in some patterns. Rim is obviously, when it is circular, means it is outlining some wall of a structure which will be oval or rounded. Most common cause is cysts. Cysts are fluid containing structure. So any cyst anywhere in the liver, the spleen, the kidney may show a peripheral rim of calcification. Even aneurysms are dilated vessels. Aortic aneurysm, hepatic, any artery aneurysm can show wall calcification. Or some organs which are in oval or rounded in shape, like GB, if it is showing wall calcification like in porcelain GB, we can have this. Okay, so let's see some examples here. So this is the X-ray abdomen. What can you see here? Can you see this abnormal density here? This one, right? This looks like calcification in the margin of this structure. This structure itself is easily identified compared to the rest of the organs. What is this structure? This may be here appearing like the kidney. If you are thinking that this is the kidney which is showing rim calcification, you may be right actually, because this looks like the anatomical location of the kidney. But even the gallbladder in a standing patient actually would appear in the same. The gallbladder and the kidney shadows overlap with each other, often difficult to differentiate. Just by anatomical knowledge I can tell. I know that this is not exactly the shape of the kidney, and the kidney periphery would not get calcified like this. This is the gallbladder. So this is at the margins of the gallbladder. Would it mean only the lateral and the medial margins of the gallbladder is calcified? What about the anterior and the posterior walls of the gallbladder? Actually, those are also calcified. It's only when we are taking a AP X-ray we are able to see the lateral margins. The AP, the anterior and the posterior walls are overlapping over each other. This is also showing calcification. If I take a lateral X-ray of the abdomen, I will be seeing the anterior and the posterior wall, not the medial and the lateral wall. If I am taking the AP X-ray, I am seeing the medial and the lateral wall. So this is calcification in the wall of the gallbladder. This is porcelain gallbladder. Another example. Okay. Again, this looks like a calcification, peripheral, rim-like, and this pattern is also on the anterior and the posterior wall. This is again a porcelain gallbladder. Okay. What is this? Is this calcification? No. This is the normal calyces and the pelvis of the kidney. This is the ureter. This is the urinary bladder. So what is this? This was a IVP film. I'm sure you guys all know what is IVP. You must have seen. It is something contrast which we inject in the body, which is excreted in the kidneys, and once we take a X-ray, this contrast is seen opacifying the kidneys, the ureter and the bladder. What I'm trying to show you is this. This is definitely abnormal. This is calcification, something rounded adjacent to the left kidney. This could have been a cyst in the kidney, which is exophytic, could have been a calculus in the kidney, but is it a calculus? No. The pelvis is there, the calyx is there, the calculus is not there in the kidney. This was actually a calcified aneurysm of the splenic artery here in this particular location. Okay. Now coming to the second pattern, if there is a linear calcification or tram-like, you have to look carefully. You see this white line here and the white line here. This is calcification. Okay, I have zoomed it up for you. This line, this is calcification. This is a lateral X-ray of the abdomen. This is the spine laterally. So a linear calcification, I have told you, would occur as expected, something in a tubular fashion, structures which are tubular. What are the tubular structures in our body? Most often blood vessels, arteries, veins, then ureters are tubular, right? There are longitudinal structures like this. So by anatomical location, what lies just anterior to the vertebral body? The aorta. And aorta is the one which very commonly calcifies as the age progresses due to atherosclerosis. So this is atherosclerotic calcification of the aortic margin. Kind of difficult to appreciate, but I am sure you would if you look carefully. Can you see this line particular here? Yeah, 1, 2. You see this here? This is again vascular calcification. These are the iliac arteries. These are the iliac arteries getting calcified, like the aorta in that particular case, iliac arteries in this particular case. One of the most common causes for vascular calcification is atherosclerosis along with diabetes. Diabetes and atherosclerosis leads to vascular calcifications. Okay, let's look for lamellar or laminar calcifications. These are which formed in the lumen of a hollow vascule. The classical stones or the calculi which we see are the calcifications. So where are the calculi formed? Kidney, ureter, urinary bladder, gallbladder. Let's see them one by one. Again, this is a rounded, clear. This is not exactly in the wall, but this is full, densely opacified or a calcified complete lesion. So this looks like a calculus. Where is it anatomically? If you see, this is the outline of the kidney. Yeah. So this looks like in the hilum of the kidney. Yeah. This is the left kidney. Can you see this? This is the left kidney. This is the right kidney. So this most likely is the right renal pelvic calculus. How do I confirm this? If I do a IVP, I can see that the same calculus is lying overlapping the shadow of the pelvis. Same patient. This versus this. This is within the pelvis. So this is a renal pelvic calculus. This is a IVP film, right? Another example. So this is, now you know, these are the calculi in the left kidney. This would probably be in the lower calyx. Calculi in the right kidney. This would also be most likely in the lower calyx. This is the shape of the kidney. The hilum is somewhere here. These are again small calcific densities. They are linearly positioned. So once you see a calculus in the kidney and somewhere along this, by anatomical location, you know that this is most likely in the proximal ureter. Okay, this is a plain film. This is not a IVP film. So this is a complete big calculus in the pelvis, calculi in the upper, middle, lower pole calyces, right, of the right kidney. This is the staghorn calculus. This is known as staghorn calculus. Again, multiple calcific lesions, rounded, seen in the pelvis, but by anatomy, I know this is the exact anatomical location of the ureter. So this is likely to be in the right ureter, multiple calculi in the right ureter. Again, a lamellar onion peel type of a calcification seen in the pelvis. This is a urinary bladder. This is a calculus in the urinary bladder. Again, by anatomical location and this characteristic shape, I can tell you this is likely to be in the urinary bladder. Okay, some calculi again here in the right hypochondrium. Is this in the kidney? If you may be right if you are thinking that this may be in the kidney, but in this particular case, this was in the gallbladder. We do X-rays for renal calculi, but not so much for gallbladder. Why? Because I'm sure you would be knowing that more than 90% of the renal calculi contain enough calcium to be seen on X-ray, and they are therefore the most common investigations to be done for renal calculi. But gallbladder calculi are most often cholesterol calculi, right? 90% of them are cholesterol calculi. Only 10% of them contain enough calcium to be seen as calcific densities on X-ray. So if you are doing X-rays for gallbladder calculi, you will be only seeing them only in 10% of the patients. Therefore, it is not a modality to be done. So in this particular case, this was calcification, calcium containing calculi of the gallbladder. This was seen in the gallbladder. Another example, these are again can you tell this is not in the kidney? The location I have told you is the same. The gallbladder kidney overlap over each other actually. But I have shown you multiple renal calculi. They usually take the shape of the renal calyces. Is this taking shape of a renal calyces? No. This looks like some marbles or some structures within a gunny bag type of a thing, a small pouch type of a thing. That pouch can only be gallbladder because gallbladder is like a pouch. These are multiple calculi within the gallbladder in this particular case. Okay. Another example, a zoomed up image showing you a linear density. This is small soft tissue density calculi seen in the gallbladder. What I am trying to show you here is there is some linear hypodensity seen within this in the form of a sign of a Mercedes Benz. So this not commonly seen, very rarely seen, but if you see it in a calculus in the right hypochondrium, this has been described. Mercedes Benz sign has been described in a calculi of the gallbladder. Okay. Now in this particular example, there are what appears like multiple calculi seen in the pelvis, right? Are they in the ureter? No, they cannot be. Ureter cannot be this much dilated. Can they be in the urinary bladder? Yes, they can be in the urinary bladder. But again, the shape is slightly bizarre, not exactly the shape of the urinary bladder. These were actually within the rectum. What are these? So if there are calcific densities within the rectum, they are known as enterolith. Lith is like a calculus, entero is bowel. So something which is forming like in the bowel, these are enteroliths. Okay. Lastly, calcifications which are not following into any pattern, but they are more like amorphous or cloud-like or bizarre, would be somewhere in the soft tissue, abnormal soft tissue masses. Okay, so we see one example here. This was a IVP film. This is the right calyces seen here. These are calculi in the kidney, but what you see here, this is a calcification, amorphous, cloud-like in the soft tissue. This cannot be the renal calculi. So there was actually a renal cell carcinoma here, tumor in the kidney, which was showing this amount of calcification. Okay. Another example, what is this here? This looks like the shape of the urinary bladder, right? Homogeneous. Can the urinary bladder show homogeneous calcification? Unlikely. This is actually a contrast in the urinary bladder. Again, this was the IVP film. So this is the IVP callus. This is the ureter which is getting outlined. This is the urinary bladder. So this is contrast. I know this with my experience and I am therefore ignoring it. But this is not due to the IVP. This is all amorphous calcification, irregular calcification seen in the upper part of the abdomen, right from the right side going across the midline to the left side higher. Can anyone tell what is this? This is in the anatomical location of the pancreas. So this is all calcification within the pancreas. This is chronic calcific pancreatitis, most commonly seen in the alcohol related pancreatitis. There are some amorphous calcifications seen here in the left side, on the right side. These were in the adrenal glands. Can I tell you, can I be sure about adrenal glands? No, I cannot be. All of them overlap. But just by my anatomical location and by my experience, I know even the adrenals calcify. If it is one here, one side up, one side down, para midline in this location, maybe I can see, I can tell, maybe this is adrenal calcification, right? What is this? This is again some calcific density seen here in the right hypochondrium. They were actually surgical clips which have been placed, staples, due to the cystectomy which has been done in this patient. The gallbladder removal surgery has been done. Okay, I show you some amorphous calcifications here in paramidline structures, but they are in the adrenal. No, here, all across. And if I do a lateral film, I can see them has multiple structures here, right? Besides this, what you also can see is this linear tram-like calcification here. This is obviously the aortic calcification. This we know for sure now, yeah. But this is not aortic. This is more like in some solid tissues. These are actually calcified lymph nodes in the retroperitoneum. Same patient. This one and this one are calcified lymph nodes. The lymph nodes are also one of the most common uh, things to calcify in our abdomen, especially post tubercular treatment, right? Okay, now this one is easier. This is a laddu sitting here, a calcified rounded big lesion sitting here. This was a calcified abscess in the spleen. Okay, zoomed up image for the same patient, and a calcified lesion here in the liver. This was a complete rounded calcified lesion seen in the liver. This was actually a hydrated cyst of the liver which was showing this calcification. Just last 2 minutes, once you have seen all this, never forget to look at the bones. There are bones also which are present in the X-ray abdomen. Once you've seen the normal structures, the soft tissue structures, the X-rays, looking for any calcifications, any other densities, extraluminal layer, then look at the bone. In this, the vertebrae definitely is showing some abnormality. This is the normal appearance. There is some hyperdensity, increased opacity in this vertebrae which appear to be collapsed. And if I am doing a lateral X-ray, I can see this collapsed vertebra. One of the vertebra above is also showing abnormality. This was pot spine, which is tuberculosis of the spine, which was giving rise to this abnormality. Another example, there is some calcification here, yeah, bizarre calcification here, but what I am showing you is these vertebral margins are also abnormal. They are all contiguous with each other, flowing opacities, lateral osteophytes. These are syndesmophytes on the lateral X-ray of the same patient. This is a case of ankylosing spondylitis. You would study it later in your orthopedic posting. Another example, okay, what is this? This is looks like a metallic density. Yeah, this is the metallic density. This looks like a metallic density. So this is unlikely to be in the abdomen. This is obviously over the clothing of the patient. But what is this? This is also a density which looks like a calcific density seen in the scrotum. Point to learn here is, do not just lay your eyes down up to the pelvis. Whatever at the margins of the X-ray also you see, you need to see. This was a big scrotal abscess which was calcified. Okay. Another example, in this particular patient you can see multiple small these calcific densities within the pelvis. This I haven't told you earlier. This is different. This could have been enteroliths. You were right if you were thinking in terms of enteroliths. They are not in the line of the ureter. They are not in the urinary bladder. But these are actually small calcifications or stone in the veins, the deep veins of the pelvis. These are known as phlebolith. Phlebo is vein, lith is again stones. You can read them up later on, but these are small phleboliths. Okay. What is this now? Okay, this looks like a knife, yeah. So is this within the bowel? Is this within the abdomen? Again, could have been, but that's too theoretical, that's too impractical. This was a small knife again in the clothing of the patient which was not removed. Yeah, so this was a small kirpan, actually you would like to call, on the clothing of the patient, overlapping. This is the job of the radiographer who's doing the X-ray, to remove the clothing, to make sure all external densities are removed before we take a X-ray. But sometimes we do end up having X-rays in which external densities are not removed. Okay, my last case here, X-ray abdomen now is showing some abnormal densities here. Yeah, they look like some abnormal densities. What are this? Can you see this? See this? Even see this. See here, this is all abnormal. And what is this? One here, one here. Let me just escape and let me just see if anyone can answer. Okay. So this looks like skull. This looks like another skull. This is a head of a baby. within the abdomen. This head, this spine is of a baby in the abdomen. This head, this spine, there are two humeri of this baby in the abdomen. So this was a pregnant patient in which an X-ray was done, almost a full-term pregnancy with twins. So there were twins in the abdomen. These are the bones of the twins which are seen. So we normally do not intend to do, but sometimes it is required to be done. A pregnant patient would undergo X-ray, and this is what you would see. With this, I thank you. If you have any comments, you may probably write. Oh, great. Aranya, you are right. You diagnosed as a twin fetus. Good. Okay. The next question I get is how to differentiate a right kidney mass and a porcelain GB. It is the pattern of calcification. Porcelain GB, I've told you, would show a outlining rim-like calcification. It is in the wall of a viscous, hollow viscous. GB inside content would not show calcification, right? It is containing fluid inside. Only the walls get calcified. So whenever you take a X-ray, you would see sharply marginated calcification in a linear, curvilinear, rim-like pattern, which will be signifying that it is in the wall only. Whereas a mass would not have calcification in the wall, it would have calcification within its content, within the soft tissue of the mass. So it will never be like a rim-like or a curvilinear. It will be more amorphous, cloud-like, irregular, bizarre, whatever word you want to use. So if you see that calcification, you would know that is in the soft tissue. If you see a rim-like or a curvilinear calcification, you would think it is in the wall. Something in the wall, maybe a kidney cyst, maybe a kidney cystic lesion, maybe a gallbladder lesion, that I cannot differentiate, because if they are anatomically overlapping, I will not be able to differentiate on X-ray. But I can tell whether it is likely to be in the cystic structure in the wall or it is a solid structure based on the different types of calcification which I have told you. An organ, difficult to differentiate, that's just anatomical, and I can give a differential. And this is not the modality to diagnose, this is just if you are just picking it up. Otherwise we do ultrasound, CT scans, and those can easily differentiate between the two differentials which you are asking. Anything else? Okay, thank you so much then. Bye bye, have a safe day. Thank you.
सर ये करना पड़ेगा।
क्या करना है? यहीं से?
हाँ जी।